Now for the eye exam. Of course, the most basic form of the eye exam that you can perform is using the Snellen eye chart, which we already talked about it in class and then we already practiced that in the lab. But the using the Snellen eye chart may not be practical for all of you. For example, if you're a physical therapist and you're working in a clinic and maybe you will have a copy of the Snellen eye chart so you can use that anytime you want. But let's say you're an athletic trainer and then you're traveling with the team on the road. You typically do not want to carry that Snellen eye chart with you all the time. So the alternative option that you can do is maybe using the near vision card. You can actually carry this little card within your kit, and then see whenever you have to evaluate somebody's vision, you can just take this card out and hold this card about 6 inches away from the patient and use that to assess the vision. But let's say maybe you can actually use something else that you might already have in your medical kit, which is an alcohol prep pad. If you're going to be using the alcohol prep pad, maybe something looking like this, you can hold this alcohol prep pad about 14 inches away from the patient's face and ask him or her to identify specific letters. So working from the big letters to the smaller letters, you can test anything from 25 to 100. But let's say when you're assessing this central vision, they can't even maybe identify the largest letter. If that's the case, you can try to do something a little bit more simple and say, okay, how many fingers am I holding? Okay, which is a much simpler task. Just ask them to identify whatever the fingers, the number of the fingers that you're holding. But let's say they can't even identify how many fingers you're holding, and you need to try something even simpler. You can maybe do the hand motion vision. You can wave your hand side to side in front of the patient to see if they can detect that motion. Okay? They don't have to detect that it's the hand. You just want them to be detecting there's a motion, something is moving in front of them. If they can't even see that, then the last thing you can test is known as light perception. So you might want to use your pen light, or maybe the source of the light, and ask them if they can identify the light, the difference in light, whether that's dark or something a little bit brighter than that. Once you stop assessing the central vision, and maybe they have a fair central vision, maybe they can actually read these letters, and you also want to test the peripheral vision, you can certainly do that as well. Now your peripheral vision is a little bit not so accurate than what you might think. So here's a quick video for you to test your accuracy of the peripheral vision. I do want you to focus in the middle of this picture where you have this nice white cross. Now, your central vision is typically really accurate. You have really high resolution image, but your peripheral vision, you actually don't have that accurate of a vision. So as you're focusing here and then looking at all these different celebrities' faces, which is actually normal pictures, by the way, it looks very distorted because your peripheral vision is not as good as your central vision. So, of course, that's not a very medical way for us to test somebody's peripheral vision. So what you can do instead is something known as confrontation visual field testing. So you're going to be standing in front of the patient right here as an examiner. Your patient is going to be standing right in front of you. This is between you and the patient is going to be about 3 feet away. And you can ask your patient to say, for example, ask to cover their right eye. And as examiner, you can cover your left eye. So you're going to be looking at each other using the eye that you have not covered. And the examiner is going to raise his or her hand over here, and this hand is going to be located over the equal distance from your eye and the patient's eye. So you can use yourself as a reference, okay? And you're going to hold maybe 1 or 2 or 3 fingers up in here and ask them to identify. Again, you're going to be using yourself as a reference, so make sure you can see the number of the fingers that you're holding and ask your patient to identify the same. Some other things you can check. You can definitely check for the pupil reaction and nature of the pupil. So the typical thing that you check and look for is known as perla. The pupils of the patient are equal in size and it's rounded in shape and it's reactive to light and accommodation. How you're going to typically test is maybe you can use this kind of a pen light and then bring the pen light in front of their patient's eye one at a time and check for the reaction. What you're looking for is a brisk constriction in response to bright light. So, by performing this pen light test, you can note if that reflex was present or absent, as well as the speed. Another test you can perform with the pen light is known as swinging light test. This test is very useful to detect a very specific condition known as relative afferent pupillary defect, or also known as RAPD. This particular condition could be caused by optic nerve lesion or severe retina disease, but here's a video of demonstration of the swinging light test and then why this could be actually useful to detect this specific condition. So let me play this video here.
Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed. Now swing the light from eye to eye, quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them.
So this is a swinging test.
Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slower response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here, the left side is affected. You will miss an RAPD if you do not do the swinging light test, as it is only by comparing the relative strengths of the signals reaching the brain from the eyes that the abnormality is detected. Finally, with a complete afferent pupil defect, there is no pupil reaction to light shone on the affected side.
So, like this video was showing, by swinging the pen light back and forth, you can specifically detect this condition. If you're just checking this patient's pupil reaction using the pen light, just one per each eye, you might actually miss this condition. You're gonna have to perform the swinging light test to detect. Some other things that you can look for, you can probably easily detect, is abnormal size of the pupil. Now, if this is something that you see after a head injury or eye injury, that's very concerning. It could indicate anything from subdural epidural hematoma, brain damage, cranial nerve damage, or significant eye injury. But I also do want you to know that this specific condition, anisocolia, unequal size, could also be benign. Some people are born with this condition, and sometimes it's just normal for the patient. There's a very famous celebrity that was born with this specific condition, anisocolia, David Bowie. If you were to take a little closer look at his eyes, you can see that he actually indeed has anisocolia, and that is completely benign for him. He was just born with it. Same thing for the shape of the pupil. Of course, you would typically expect this to be very round shape and equal, again, in size. After significant eye injury, if this is what you see, you need to be very concerned, because that might indicate a very serious iris damage or cranial nerve damage. But again, some people are born with this abnormally shaped pupil shape, so having the patient's history is going to be crucial. Is this normal for you? Is this something that you developed after an injury? Another thing you can check for is the eye motion. So you can ask them to, okay, I want you to look at my finger. Without moving your neck, I want you to follow my finger. And what you can perform is often known as H test. You can move your finger to one side, go up and down, move to the other side, go up and down to check for eye motion. By performing this test, you're checking the cranial nerve number 3, 4, and 6. Some other condition that you can also see, swelling. Ecchymosis is a very common finding during the eye examination, especially if it's a traumatic injury. But if your patient developed this kind of swelling with no history of blunt trauma, you might want to consider a possibility of infection. Let's say your patient said, he or she woke up with this kind of a swelling and it's really sore to touch. That might indicate an infection. In this particular case, this picture actually indicating the case of STI. Some other things if you're gonna be visually examining the patient's eye, make sure you're trying to really look the entire anterior aspect of the eye, meaning that you might need to actually hold the patient's face, okay, maybe down here, and then ask them to look up so you can see the entire kind of inferior aspect of the eye. Same thing for the superior aspect. You can actually grab the eyebrows and then pull them up a little bit and ask them to look down so you can again see the entire anterior surface of the eye. Consider adjusting the room right, especially after eye injury. It's very common for people to it's not uncommon for some patients to develop a sensitivity to light known as photophobia. So if that's the case, you might want to consider darkening the room a little bit for the patient so they'll feel a little bit more comfortable. There's some maybe obvious things that you might be able to see, something like laceration or cuts around the eye. Some are a little bit more minor, some are a little bit more severe than others. If it's a nice big cut like this, that might require immediate referral. Some other things you can see, maybe some gooey stuff covering their anterior eye, maybe with a little bit of swelling. This picture is showing a good case of conjunctivitis, looking like this person got a nice bacterial infection. So again, another sign of immediate referral. They need to be start taking some antibiotics. What do you see in this picture? Well, what I see is a little bit of accumulation of the blood over the anterior chamber of the eye. Now, sometimes this is just a little bit of amount of the blood. It's possible for almost maybe entire anterior chamber to start to fill up with the blood. So this condition is known as high femur collection of the blood over the anterior chamber of the eye. This would often indicate a very serious eye damage, maybe even sight-threatening conditions. So if you ever see this high femur in a patient, you should consider immediate referral. Now, it's possible for some people to develop spontaneous high femur, maybe with no history or indication of trauma. Maybe they have a little bit of an arterial disease or some kind of a intraocular pressure increase kind of a condition, and that might be leading to some kind of a untraumatic bleeding out the eye, and that's a possibility. But if you ever see this, you should suspect the worst case scenario, eye-threatening condition, and make immediate referral. You can use a ophthalmoscope to examine the inner structure of the eye. We already kind of talked about this and even practiced this in the lab today, so I'm not going to repeat that entire lecture again. And I also know that you actually watched this video of people demonstrating how to use the ophthalmoscope, so I'm not going to play this video one more time, but you can go back to the video and then watch it again if you need a little refresher here. But what I definitely want you to know about this ophthalmoscope is check the red eye reflex first. Okay, so you need to darken the room. You're going to use this large lounge shaped setting with the really bright light. Okay, and you're going to use that light to look for the red reflex. Remember the red reflex, what you're actually seeing as a red color is a reflection of light running through the dilated pupil, and this is just actually the reflection of light against the choroid layer, really highly vascular layer. That's why you see this nice red color. And this picture right here showing a normal ophthalmoscopic view. What you see right here again is the bright spot, which would indicate optic disc, where your optic nerve is going to enter. And this dark area would represent the macula, as well as this really darkest spot, typically right in the center, is the fovea. You see artery and vein running from the optic disc and then running towards the macula. Again, here's a normal picture of the ophthalmoscopic view. If you see really dark macula, or the macula almost disappearing, and then you see some yellow orange looking dots, that might indicate the macular degeneration, abnormal retina. It's not uncommon for a patient with diabetes to start to develop some retina issue. Some other very common signs and symptoms will be maybe necrosis in the foot or neuropathy, but retinopathy, abnormality over the retina, is also another very common manifestation of the diabetes.